All right, it's 12:30, so I'm going to get started. So welcome everyone. Thank you for joining us for the South Texas Regional Family Medicine Grand Rounds. Next slide, please. So thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaging the session, keeping your cameras on when appropriate, registering for CME credit for each session, and completing and submitting a session evaluation form. Next slide, please. So here's the activity code for today. I'll leave this up here for a little bit so you can all claim your credit. All right, next slide, please. So again, here's the activity code for today as well, instructions for getting your CME credit. So I'll leave this up here for a little bit as well. All right, next slide, please. So this is just information regarding getting your CME transcripts. Next slide, please. And this slide is just regarding the AAFP credit system. Next slide, please. And then these are just the FCM Grand Round core competencies. All right, next slide, please. So Dr. Khorshid Amirkhosravi and Michelle Davis, they have no financial relationships with ineligible companies to disclose. Next slide, please. All right.
Well, good afternoon, everybody. Thanks for coming to Grand Rounds. I'd like to introduce our speakers. Dr. Ari Amirkhosravi received a bachelor's degree in biology at Lamar University and a bachelor's in biochemistry at the University of Houston. She graduated from medical school at St. George's University. While applying to residency, she worked as a research coordinator on the Moderna and Pfizer COVID vaccines. And she is currently a third-year medical resident at the University of Texas Health Science Center, San Antonio, Family and Community Medicine residency, and serves as one of our chief residents. Michelle Davis is a PGY3 and administrative chief resident at the University of Texas Health Science Center, San Antonio. She attended medical school at Burrell Osteopathic Medical School. And with that, I'll turn the podium over to them and let them do their presentation. Thank you.
Thank you, Dr. Nato. Hi, everyone. I'm Ari Amirkhosravi. So today we are going to talk a little about the comparison between different treatments for the mild to moderate acne. Alrighty, so we are going to have a little introduction about the acne, the epidemiology of the disease, the pathophysiology of it, and the current treatment that we use. Also, we are going to look at the one of the articles published in Poems of 2022 from AAFP and look at the study design for that article, look at the method, results, and discussion. And at the end, we're going to talk about if that article has changed our mind or my mind regarding the treatment of the acne in the patient population that we see. So a little bit about acne. Acne is one of the most common conditions that we see during our primary care visits. It is present in both adolescents and adults and have profound physiological impact such as low self-esteem, depression, anxiety, in addition to sometimes the scarring that will remain. Alrighty. So it's most observed in adolescent and young adults, and the prevalence ranges between 35 to 90% among the adolescents. So it's a very wide range, but the course of the disease can be seen as early as 7 to 12, and it usually resolved by the third decade of life. If you see the acne prior to that or after that, we most likely will investigate to see what would be the other causes of that. But it affects mostly male in adolescent and females in the post-adolescent age groups. Approximately 20% of the affected individual will develop severe acne, which will result in scarring. So a little about the pathophysiology of this disease. So it starts with the stimulation of the sebaceous gland by circulating androgen, which leads to seborrhea, which means sebum production. Then seborrhea provides a growth medium for the Cutibacterium acne. Cutibacterium acne is is a prominent bacterium basically within the microbiome of everyone's skin. So now the Cutibacterium acne in turn hydrolyzes the triglyceride in the sebum to free fatty acid and glycerol. Now it has provided itself with a nutrition-rich environment, which causes the C. acne to thrive. So the overgrowth of the bacteria triggers the innate and adaptive immune response, an inflammatory response, which then causes the acne. Sometimes genetic also plays a role in development of acne. This is a picture of the hair follicle unit, basically, and now we're going to look at the types of acne. There are 4 major grades of acne. The grade 1 is the comedones, which itself has 2 types. It has an open type and a closed type. The open type is when the pilosebaceous orifice becomes plugged with sebum and appears as a papule with central dilation follicular orifice, which this type can appear as gray, brown, or black. And then we have the closed comedone, which when the keratin and sebum clogs with the pilosebaceous orifice beneath the skin surface. This appears as a dome shape, smooth papules that can be skin color, white, or grayish in color. Now, the grade 2 is the inflammatory lesion as a small papule with erythema. Grade 3 is now pustule formation, and grade 4 is many pustules coalesce to form the nodules and cysts called the nodulocystic form. We can also categorize the acne based on mild versus moderate. So with the mild type, it's the scattered small, usually more than 5 millimeter, is comedonal or inflamed and limited skin involvement. It is in this type, you don't see nodules or scars. The moderate or severe type is visually prominent. It consists of many comedonal or inflamed papules. It has nodules formation, and a lot of time it is associated with scarring. There are different types of treatments that we can use when we see our patients. We can have the topical retinoids, which this medication or the type of vitamin A, it binds to retinoic acid receptor within the keratinocytes. It stimulates the transcription of the regulatory genes. It normalizes the follicular keratinizations, and it loosens the cohesiveness of the keratinocytes, which in turn decreases the formation of the comedones. Benzoyl peroxidase, it has the comedolatic and antimicrobial properties. It should not be applied with the retinoids because it causes the oxidation of the teratoin. So usually when we prescribe the medication, we give the benzoyl peroxidase to be used in the morning, and then topical retinoid mostly is used at night because using it in the morning with the effect of sunlight, it can have more side effects. Then we have the topical clindamycin and then topical erythromycin. Clindamycin is usually given prior to erythromycin because there is less resistant to clindamycin than erythromycin. And then we have the azelaic acid, which also is comedolytic. It has antimicrobial and whitening effect. Mostly it's given if a patient does not tolerate the topical retinoids. And then we have the topical salicylate or salicylic acid as well. So this is just the flow chart about how do we choose the medication. All right. So if so we look at the acne scarring, we look at the psychological effect or psychological distress regarding to acne, and if there is a post-inflammatory hyperpigmentation, basically the severity of the disease in our patient. So if these are absent, then we assess the lesion type. If it is present, which we're not going to talk about this during this presentation much today, but if it is present, if all those three are present, usually we can go with the systemic medication. But if it is absent and we go this route right here, then we look at the lesion types. If it is a comedonal lesion only, then we would choose topical retinoid first. Then if the treatment is unsatisfactory, we can increase the dosage of that medication or change the different type of the retinoids. If it is satisfactory, then we will continue with the maintenance treatment for our patients, which continuation of the retinoids. Now, if you see the papulopustular comedonal and the comedonal lesion, then usually we try to choose the combination medication, which will be topical retinoids and benzoyl peroxidase. If it is satisfactory response at this time, then we usually continue for 3 to 6 months. If the patient gets better, then we can choose to go to the monotherapy. If it is unsatisfactory, then we have to choose alternative topical treatments. So this is just, again, the most common type of the treatment that we just talked about. Now, let's talk about the article that I mentioned at the beginning of the talk. So the title of the article was Topical Preparation for Treatment of Mild to Moderate Acne Vulgaris, Systemic Review and Network Meta-Analysis. The objective of the study was to identify the most effective and the best tolerated topical treatment for mild to moderate acne. And the method used was network meta-analysis. So the guidelines differ in their recommendation and the quality. That's why they tried to do this study. So the study was done in England, and the National Institute of Healthcare Excellence Clinical Knowledge Summary is the one that is used in UK. And they suggest the first line to be a single agent, a topical treatment followed by the combination. This is also true for the US, as I mentioned, but that depends on the severity of your acne. So you can choose either the single therapy versus combination. There is uncertainty regarding the initiation and the maintenance and the dosage of the treatment, and also are the antibiotic therapy necessary at this point or not? So they try to kind of answer these questions on this article. So for the study design, they used the network meta-analysis. So in the traditional meta-analysis, it's limited to direct head-to-head comparison between network of the meta-analysis technique. But in the network meta-analysis, all available data are used to build a network of direct and indirect comparison. So it allows estimate of effectiveness of treatment in addition to estimate of incoherence of how well the whole network basically fits together with different medications. So the method for this study, prior to starting the study, they decided to have a panel of 10 people with a current or former acne and try to ask them what would be the most important thing for them to observe on this study. So what would be the primary measure? They decided that the primary measure of the study would be how effective is the treatment and how is the adverse event based on the patient's opinion, basically. So patients' assessment of their own acne, which mattered the most to the patient. So the search was conducted using the database such as Cochrane Central Registry of Controlled Trials, Medline and MBAS database. They use the World Health Organization. They use other journals. They looked at the randomized control trials, but they excluded the trials that use the method of split body or split face. So that's the type of method that they apply the medication on one part of the body and not the other, and then compare it later on. They also choose 2 reviewers independently looking at these papers, and if they had disagreement, they would have a discussion to come up with a solution. The eligibility criteria for this study was that the participant had to have mild to moderate acne, which was defined by the trial authors. And in the trials, they also choose the trials that they had the mixed population of the acne severity, provided that less than 50% had the severe acne. They excluded trials that were not randomized. Also, they excluded trials that reported on other types of acne. For example, the truncal acne, the unusual acne, infantile acne, occupational acne, drug-induced acne, or acne associated with the endocrine issues, for example, the PCOS. They also excluded the patient or the trials that the patient used during the trials have used the oral tretinoin or isotretinoin previously, and they were using the trial basically just as a maintenance. So they excluded those as well. So the primary outcome of the study was proportion of the participant self-reporting moderate or better global improvement in their acne, and also proportion of the participant withdrawing from the trial or cessation of the trial medication because of the adverse event. They looked at the secondary outcome of the trial as well. So it looked at the change in the mean total lesion count from the baseline that was basically reported by the investigators themselves. They looked at the proportion of the participant rated clear or almost clear on the investigator global assessment, which is a type of questionnaire. They also looked at the change in the quality of life from the baseline. This is also a questionnaire. They used questionnaires such as the Skindex 16, Skindex 29. They looked at the reduction in the Cutibacterium acne strain. That's the prominent bacteria that can cause acne, and in the total number of the adverse events, and also participant satisfaction with the treatment. So they, at the end, they chose about 2,717 references. They removed the duplicates and this whole thing was reviewed by 2 investigators. They had about 81 full text reports on 40 trials. The most common treatments that they observed was benzoyl peroxidase, BPO, compared to the vehicle. Vehicle is the cream or the vector that they use without the active product. It's followed by the adapalene, which is type of teratolin, and the adapalene and BPO come together compared to the vehicle. So the data that was collected, they observed that mean sample size for this study was about 454 participants. The average age that was reported was about 20 years old, and then 57% were female. 50% were from North America, 29% from Europe, 24% from Asia, and 5% from South America, and 3% was reported from Australia. And from all these trials, about 54% of it was sponsored by pharmaceutical companies. So that was a lot. So this is just a list of the medication that was reported. As you see, they used the azelaic acid, adapalene plus the benzoyl peroxide, antibiotic and antibiotic combination with the benzoyl peroxide, isotretinoin and erythromycin, and so forth. So now looking at the result, the patient global assessment improvement reported in about 11 trials. All the treatments were more effective than vehicle, which as it was expected. The adapalene and BPO, the benzoyl peroxide, had the odds ratio of 3.65 compared to the vehicle, which means that the medication was 3.65 times more effective than not active ingredient. The clindamycin and BPO had the odds ratio of 1.22. The clindamycin and BPO was more effective than the clindamycin alone or BPO alone. Now, looking at the adverse event and the withdrawal from the event, it was reported in about 35 trials. Clindamycin was associated with the lower odds of withdrawal than the clindamycin plus benzoyl peroxidase alone, or the adapalene and benzoyl peroxidase together. The highest odds of withdrawal was the adapalene plus the BPO, so it's supposed to be a plus here. The total lesion counts reported, that was another secondary outcome that they were looking at. So they saw that the highest decrease of lesion, again, was observed in those using the combination medication of the teratolin and the benzoyl peroxide. And second ranked treatment was the clindamycin plus the benzoyl peroxide. However, the confidence was low. So another secondary outcome that they were looking at was investigators' global assessment, which was reported in about 14 trials, and that demonstrated improvement in the IGA, that's the questionnaire we mentioned, to clear or almost clear. So all treatments were significantly more effective than the vehicle, okay, which was good. And again, they saw that the adapalene plus BPO was significantly more effective than all the other treatments, apart from the clindamycin and BPO. So this is again the chart that they reported the results in. Looking at it, so the patient global assessment of improvement, that was the primary outcome that they looked at. And as you see, this is the side with the vehicle, this is the side with the treatment, and the adapalene plus BPO had the highest, okay? And then the clindamycin plus BPO had the second. All right, looking at the lesion count, Again, this is the type of the that favors the treatment. Looking at it, the combination medication was the most effective. And looking at the investigators' global assessment and what they thought about the acne, again, the combination was the most effective. However, looking at the withdrawal due to the adverse event, again, you see that the combination had the most amount of adverse event. So it was give and take basically here. So this is just looking at the ranking of the medication, which again, looking at the improvement, the combination was number 1. The clindamycin plus BPO was number 2. However, the confidence was low. The tretinoin by itself was number 3, and retinoin, which is another type of vitamin A, which was number 4. Looking at the withdrawal, again, the combination had the most adverse event. Erythromycin plus the tretinoin, second one. BPO itself was the third. So looking at it, tretinoin was number 4, and the Adaplane was number 3 on the improvement, and number 7 on the adverse event. So not a bad ranking. And Adaplane is a medication that in the US can be used without a prescription. And isotretinoin, I don't know if it's not reported here, but it was reported in some of the studies that medication is not approved in the US. So the discussion or the final points of the study was that the Adaplane plus the BPO was ranked the most effective treatment for all included outcome, but also it was associated with the highest withdrawal from the studies. It suggested that the non-antibiotic treatment were more effective than first-line treatment than the antibiotic treatment, for example, clindamycin and erythromycin. Again, those medication, the antibiotic shouldn't be given by itself without the benzoyl peroxide because it can increase the chance of bacterial resistance. So looking at this study, first of all, what did I think that were some of the flaws to the study? There were poor reporting of the study method based on the authors of this meta-analysis. The substantial number of trial was had the industry or the pharmaceutical involvement, which can skew the result. The blinding was done in some studies. However, the BPO and retinoid can also cause redness. So they could kind of tell who had the medication and who did not because of the side effect of the medication. Also, the different skin types have different type of reaction to the medication, and they didn't mention anything about colored skin or basically different skin types. Let's see, and data and the adverse event were poorly reported, and the reason for patients leaving the study were not reported. They also didn't mention that if the acne, so they did look at the different medication, but they didn't say how bad was the acne itself. So would I use the study in changing my practice now? I probably wouldn't start with the combination medication in all patients because of the side effect. That would be an individualized, basically, treatment for my patients. If they come in with the bad enough acne and they and with the effect of with increased psychological effect because of their acne, maybe I go ahead and give them the combination medication. But as of right now, I would again go with the same method that we discussed at the beginning, looking at if it is severe enough for me to give the combination versus not, and then go from there. Okay, thank you so much. And this is my references. And if you have any questions.
So Ari, if I could just make a comment, and that is, I think a lot of times the effectiveness of the therapies depends a lot on patient factors. So spending a little time making sure the patient understands what you're trying to accomplish, is going to be consistent with the treatment, is going to apply the medicine correctly, that sort of thing is really important.
Exactly. Okay, there are no other questions. I'm gonna have Dr. Davis continue with her presentation. I'm gonna stop my share so you can go ahead.
Okay, let me just load up my screen. All right, I believe I'm sharing now. Thank you, Dr. Amirkhosravi, for that excellent presentation. And thank you again, Dr. Nato, for the introduction. I want to, while I load this up, thank everyone for their time today and for their attention. And so my presentation today, my poems, will be discussing the Irritable Bowel Syndrome Management Guidelines as updated by the British Society of Gastroenterology. So today's objectives are to identify what IBS looks like in its clinical presentation when a patient reports their concerns to you, as well as to understand and identify the different classifications of IBS. We also want to, after today's presentation, be familiar with the Rome 4 criteria, which I'll go into more detail on, but basically the Rome 4 criteria is the gold standard approach to diagnosing IBS to date. And then besides that, we want to be able to understand and apply the British Society guidelines for diagnosing and managing IBS. And then lastly, how do we take these recommendations, these treatment options, and apply them to our patients? And also, how do we understand their graded efficacies? So just a little bit of background on irritable bowel syndrome, or IBS. It remains one of the most common GI disorders, both in primary care and by gastroenterologists. Even though it is one of the most common GI disorders, it is understudied. And what I mean by that is basically the few epidemiological studies that we have only conduct studies or follow-up to a year's worth, basically, up to 12 months. And then most of the drug trials for IBS are conducted within a 3-month period. So any data or any effects after these timeframes are not known. These factors in terms of what's helpful and what's not so helpful in the management of IBS still needs to be determined. It's unclear right now. But otherwise, what studies have shown is that IBS is considered or has been retermed a disorder of gut-brain interaction. We know that our nervous system plays a role in the GI tract, and so they feel that there's an increased sympathetic nervous system activity and a reduced parasympathetic activity, and so that dyssynergy between the two nervous systems is what causes the abnormal symptoms. We also know that from our studies so far that stress can play a role in IBS and can exacerbate symptoms by specifically reducing vagal tone and impacting gut permeability, motility, increasing inflammation, things of that nature. And so what does IBS look like clinically? Here's a handy table that the article provided, kind of reviewing the clinical factors that are needed to diagnose it based off the Rome 4 criteria. And so basically a patient has to have a total of 6 months worth of abdominal pain, averaging at least 1 day per week. And in order to specifically term it a positive diagnosis for IBS, they have to meet this criteria within the 3 months of you evaluating them. Their abdominal pain has to be related to defecation in some sort, either worsened or improved with defecation. They have to, besides that, can have either, change in frequency of stool or a change in their stool form. In addition to meeting those symptoms, like I said, they have to have had the symptoms for 6 months, and meeting specifically that time frame in 3 months. And then this table also kind of classifies the different forms of IBS. We know the two most common forms are the constipation form and the diarrhea form. There's also a mixed form where they can have alterations in their stool habits, and then an undetermined version where they don't necessarily meet either of the 3 criteria, but otherwise have symptomology that is reflective of an IBS picture. Some things to note, whenever a patient comes to you with concerns and you're figuring out your differential, we always want to be mindful of the most acute pathology and some alarm findings that would suggest otherwise. So this article provided a handy table about some alarm findings that would push you to do more acute intervention or kind of lead away from an IBS differential and something more prominent. So you can refer to this table here, but I would note you to the definite referral criteria would be any positive fecal occult blood test, or they determine it by age. So a patient 40 and older with the abdominal pain picture and unexplained weight loss, the patient who's 50 years and older with the above symptoms, but also rectal bleeding due to an unknown source, or a patient 60 years and older with anemia as a consequence of their bleeding, changes in bowel habit, or any other acute symptom. So just be mindful if a patient reports IBS-like symptoms, but also has these concerns, that would prompt you to a more immediate evaluation. How do we start our diagnostic workup for IBS? We, like with any patient, want to obtain baseline labs. So we'll get a CBC to look for leukocytosis. We'll get inflammatory markers like a CRP and ESR. And then you'll want to throw in other labs at the same time, like celiac serology. This is because celiac disease can have some overlapping symptoms to IBS. And since celiac disease is a little more understood or studied compared to IBS, it's something that we have more definite treatment for. So if we can diagnose that and provide the patient with that more definite treatment, let's do so. So I would order that serology. In addition, especially in a patient who's under 45 years of age and having more of a diarrhea presentation, you can throw in a fecal calprotectant to kind of rule in or rule out a differential for irritable bowel disease. Additionally, if the patient meets screening guidelines for colorectal and ovarian cancer, now's a good time to order it and obtain that colonoscopy, for example. And then GI referrals are always warranted if the diagnosis remains unclear or if your first-line interventions are ineffective. So this article that I'm going to discuss today, it's the British Society of Gastroenterology guidelines on the management of irritable bowel syndrome, based on the self-titled study. It's written by Drs. Payne, Black, and Vassant. It was published in 2021, and it's specifically from the Gut Journal, and that's part of the British Society of Gastroenterology. This article is considered a practice guideline. What a practice guideline is, it's basically an authoritative framework of evidence-based recommendations that a provider like ourselves can refer to for ease of diagnosing and managing a condition. It has the most up-to-date guidelines that have been studied in last recent years. It's very useful, especially in a specialty like family medicine, where we have to cover a lot. We have a wide breadth of knowledge, and so something to refer to like this is very useful. This study specifically, their primary aim was to update guidelines from the previous in 2007, specifically trying to clarify treatment of IBS. And its secondary aim was to not only identify novel treatments that are currently being studied, but to kind of help highlight areas of unmet need and where further research is needed. So there was a lot of analysis that went into putting together this practice guideline. Systematic literature was completed on studies since the last guideline in 2007, and they applied different scoring systems like the Oxford one, this grading of recommendations assessment, and the appraisal of guidelines. Basically, these scoring systems helped determine whether studies were eligible, meeting criteria for review, helping to determine the strength and quality of the recommended treatment protocols. And then also when they built their practice guideline that we'll review, they used this evaluation, the appraisal of guidelines for research and evaluation, to develop their specific protocol. So a lot went into building this guideline. What this practice guideline found were updates specifically to the Rome 4 criteria. Previously, the Rome criteria has always been used to diagnose IBS. We're now in the Rome 4 as of 2016. They found that the Rome 4 was more specific than its predecessor, Rome 3. And things that differentiate it from Rome 3 is terminology. So Rome 4 removed the term discomfort and now refers to abdominal pain. So a patient must report abdominal pain because they found the word discomfort was more vague, and it led to misinterpretation, especially across different nations and different languages. They also increased the minimum required frequency for abdominal pain. So before, with Rome 3, you had to have pain at least just 3 days a month. Here you have to have it at least 1 day every week. So by increasing the amount of pain a patient experiences, that pulls in less patients who could have the disease, reducing the risk of false positive diagnoses. Additionally, the abdominal pain, like I mentioned before, has to be just related to defecation, either improved or worsened with defecation. Before, it was only supposed to have been relieved with defecation, but they found that patients were reporting even worsening pain. And so to kind of highlight how Rome 4 is more specific and kind of a little more stringent in its criteria, here are some studies. So the Rome Foundation Global Survey studied the potential diagnoses for IBS in 33 different countries and found 73,000 adults with it. When comparing the prevalence, though, using the Rome 4 criteria, only 4.1% of worldwide prevalence of IBS, whereas there was a 10.1% using Rome 3. Additionally, using Rome 4, there was a higher pooled prevalence of IBS in women compared to men. They didn't give the stats for how many women using Rome 3, but they did note that it was more specific with women using Rome 4. And then this other study in 2012, when looking at that data plus the Rome Foundation Global Survey up here, combining the two, in 38 countries, 400,000 adults were diagnosed with IBS, but they found a 3.8% prevalence worldwide using Rome 4, much less compared to the 9.2 using Rome 3. So I'm a visual learner, and I thought that this was great that this article provided different algorithms to kind of paint the picture instead of just words about how to approach IBS. So I included this here for your reference, but we'll go more into detail when I give the recommendations. Basically, when a patient starts reporting IBS, you want to take a focused history, build your differential, order some basic lab work, start your first-line interventions, and then you can always escalate to secondary care if needed. And then here's another algorithm that they provided, kind of giving a different way of showing how to approach it. But I want to make note that there are 4 different categories here that we'll go into. So this practice guideline divided its recommendations based off these 4 categories. So how do we approach and treat IBS in terms of a general communication and conservative approach? How do we do it with first-line interventions, second-line treatments, and then, of course, psychological therapies? So I'll go more into detail right now. I do want to note that this practice guideline was very extensive. It was a 20-something page article going over different recommendations, both strong and weaker recommendations. Given the breadth of knowledge that we family physicians have to know and rely on in terms of managing our patients, I thought it was more pertinent to include the strongest recommendations. And so the following is the goal here is to give you the strongest, most high yield points to take away from, and for hopefully you all to refer to when you're faced with patients with these concerns. So starting with the doctor-patient communication category, they found strong recommendations for, of course, establishing an effective rapport and relationship with the patient. This is intuitive. We want to make sure that a patient has a good understanding of their diagnoses, their concerns, and how do we move forward with next steps. Additionally, patients expressed across studies that they would like increased empathy and support with this diagnosis since it is a complex disorder, but also they want more information from clinicians. So we all know it's not just enough to tell them you have this diagnosis, here's what we're going to do about it. Educate them, make them empowered in their decision-making as well. Moving on to the diagnosis category of recommendations. So there was strong evidence and or strong recommendations and moderate quality of evidence for the first line workup. So like I had mentioned, getting a CBC, inflammatory markers, serology, and fecal calprotectin, starting with that workup to kind of build and narrow down your differential. And of course, getting like further workup for like colorectal and ovarian cancer screening if applicable. And then also making that positive diagnosis of IBS based on the symptoms and identifying any alarm symptoms if present. Some other strong recommendations in terms of diagnosis and education. So they clarified that there is no role for colonoscopy in IBS. I know it might be reflex for some clinicians to consider colonoscopy anytime there's lower GI symptoms, especially if the patient is meeting screening for colonoscopy. But in terms of IBS for sure, or diagnosing it, there's no role for it. And that's because IBS doesn't affect the intralumen of the intestines itself. So there will be no visual pathology on colonoscopy to be identified compared to like IBD. And so really your role for ordering a colonoscopy when considering IBS is just to rule out the alarm findings. Or if you're considering a differential of like microscopic colitis, and of course I've left some risk factors to consider for that here for your reference. There's also no rule for testing for exocrine pancreatic insufficiency specifically, especially if a patient is not having like the fat malabsorption diarrhea, or testing for hydrogen breath testing if they're not meeting the criteria for like an H. pylori infection picture. Again, another strong recommendation is that the diagnosis of IBS, its pathophysiology, common symptom triggers or exacerbators should be discussed with the patient, make them empowered so that they know how to best manage it in their own way at home, and also informing them about the fact that it's been retermed a disorder of gut-brain interaction and knowing that it can have psychological impact on them. Moving on to first-line treatments. So all across the board, these were strong recommendations with mostly some weak quality of evidence. I did include these even though the evidence was weaker, just because we know that in general, IBS research still needs to be developed. So this is going off of what research we have. Of course, like with any patient, regular exercise should be counseled on just because routine regular exercise helps promote psychological well-being, mental well-being, physical, general well-being, helps with gut motility as well. Some other first-line interventions are dietary advice, specifically just counseling them on a regular healthy diet, frequent regular meals, limiting exacerbating sources like spicy intolerant foods, any allergen foods, or caffeine. And then they also noted that patients might ask you about specific diets like celiac disease or allergies to yeast. And so diets based on those specific antibodies, they don't necessarily need to follow those types of restrictive diets if, you know, those foods aren't necessarily exacerbating their symptoms. Also, soluble fiber like our psyllium products, they did find moderate evidence that it's effective in treating not only the global symptoms of IBS, but specifically the abdominal pain, whereas insoluble fiber is not as effective. And like with any medication, you want to start low dose, so about 3 to 4 grams a day of soluble fiber and build up slowly just so you're not exacerbating the bloating side effect that can come with it. Additionally, there's some early evidence that loperamide might be effective for the diarrhea category of IBS, just noting its side effect profile as well. Second line treatments. So given that IBS is considered a gut-brain disorder itself, they felt that a medication like tricyclic antidepressants can be useful in helping with that neuromodulation effect, specifically with the pain itself. Of course, you want to be careful in patients where the side effect profile can be more alarming, especially with the anticholinergic effect of TCAs. And so just be mindful of those and start off with low dose and slowly titrate up if appropriate. They also found that linaclotide, it's a guanylate cyclase C agonist, and that actually has high quality of evidence for helping with constipation. It's a secretagogue medication that helps by pulling in water into the GI tract, helping speed motility, and so that's why it helps specifically with constipation. Some more secretagogue medications are lubiprostone and plecanatide. These also help with the constipation effect based off the similar mechanism of action, and these have pretty high ratings of evidence so far in early studies. Additionally, we have tenapanor and tegaseride, which have the same mechanism of action. The one thing to note here is that unfortunately tenapanor, it is available in the US, but not in other countries, and so studies on that are limited. On the opposite end, tegaseride is available in other countries, but not approved in the US, or I'm sorry, outside of the US as well. And so studies are limited here, but what has been done or studied so far is effective. Moving on to the psychological therapies of IBS. So IBS-specific cognitive behavioral therapy has low evidence of being effective right now, but is strongly recommended just because we are seeing the psychological impacts that are related to IBS. And I think the quality of evidence is low just because beforehand studies didn't factor in the psychological components before, but now we're seeing it. And so I anticipate further evidence coming in with more research. We all know, especially with our behavioral health consultants in clinic, how effective those interventions are, how useful they are. And so I would personally be a strong proponent for this myself. Other evidence or studies looked into gut-directed hypnotherapy that has low quality of evidence, and then some other psychological therapies like counseling, especially for patients who have been dealing with this disorder for so long, have distress from their symptoms, especially at the 1 year mark. This would be an appropriate referral for them. Of course, you can always include psychological interventions sooner than the 1 year mark, but they were specifically recommending at this point. What happens when a patient has management or has severe or refractory IBS? Unfortunately, there were not a lot of new recommendations or strong recommendations on this category. Most of them were weak or not even studied at all. And so the one strong recommendation was, of course, when a patient has severe symptoms, at that point refer to GI. But by no means should you induce any iatrogenic harm by prescribing some medications or doing diagnostic workup that isn't indicated or that wouldn't change your management, especially if there's financial or reputable gain for you doing so. So those were the strongest, most positive recommendations that this study indicated. I did want to include in this next section, these are recommendations that either clinicians have considered before, or patients might ask you about, that were actually found to be low in evidence or quality of evidence, and were found to be weaker recommendations. So I thought it was interesting, and I hope that you take this presentation, and if a patient asks you about these specific treatments coming up, you can pull this up and show them that they're weaker recommendations and more studies need to be done. So interestingly, they said a referral to GI is in secondary care is a weak recommendation, but specifically they were just noting that you can refer to them whenever the diagnosis is unclear or there's the alarm findings. But if the diagnosis is clear and management is working with first-line interventions, you don't necessarily have to refer to GI right away. Also, diets that are low in fermentable oligosaccharides, disaccharides, monosaccharides, such as like considered the low FODMAP diet. It's a second-line dietary therapy, and it has limited evidence in being effective. I know I've personally had patients who have asked me about that, and I've provided them with information on this diet in their AVS, but now I can show them this evidence showing that it may or may not be effective and studies need to be done further. Additionally, probiotics as a group may or may not be effective in helping with symptoms, particularly because probiotics, there are different types that target different strains of bacteria. And so as a whole, it's recommended that a patient not be on probiotics for longer than 12 weeks at a time, just because the evidence has been not shown to be very effective past that time frame. Additionally, a gluten-free diet, just based off the mechanism of the diet, is not recommended in IBS because of its different pathophysiology. Certain antispasmodic medications also may or may not be effective in patients, and at this point you want to consider risk versus benefits of their use, considering their side effect profile like dry mouth, dizziness, visual disturbances, especially in your older patient population. And then our good old Miralax polyethylene glycol, it may or may not be effective in some patients. It's not going to necessarily harm them if they try it, since Miralax is such a common medication that we use, but this evidence is low specifically for IBS. Kind of like the TCAs, SSRI therapies have been considered possible treatments for the gut-brain neuromodulator effect of IBS, but this study concluded that TCAs were found to be a little more effective, whereas SSRIs had low quality of evidence. Additionally, rifaximin, the antibiotic that we normally use, like in cirrhosis, it had a moderate effect as a second-line drug for IBS, specifically the diarrhea component. But again, they concluded that despite its moderate evidence, further studies need to be done. So those were the general recommendations that I hope were helpful in clarifying things up for you all. What this study, when looking at it as a whole, I felt like there were a few limitations. One of them was that the authors who performed the systematic literature review, they did invite a few patients to participate in that review. And so I felt like patients with IBS might have might include some biases with that if they felt like certain articles related more to their specific symptoms than others. Additionally, this article, when talking about the Rome 4 criteria, it labeled it as a restrictive diagnostic approach to IBS, and then it compared it in like one or two sentences to this NICE guideline, the National Institute for Health and Care Excellence, and it ultimately said that this NICE definition or criteria for diagnosing IBS may be preferable. And it was just like one sentence where they make this comparison. And so I felt like it was very unclear, that they should have discussed this NICE guideline more, or it was kind of outside of the scope of the practice guideline in general. So I felt like that kind of limited their discussion on the criteria aspect as a whole. Main summary points. So we can see clearly that IBS is a complex disorder, and further research needs to be done, especially in terms of defining the most efficacious medications for it. We can see that the Rome 4 criteria does increase diagnostic specificity, and so I would encourage you to rely more on the Rome 4 compared to Rome 3. And then additionally, we see that the IBS condition is multifaceted, and so you should have a multidisciplinary approach, not only within ourselves as the frontline physicians, but including GI when appropriate, and our psychologists and dietitians, just to provide the most comprehensive care and most evidence-based care for our patients as possible. And so how do we apply this moving forward? Basically, I know that since this is the most up-to-date guidelines on how to approach IBS, I will be referring to these strong recommendations when when discussing with my patient or approaching my patients with IBS. This article emphasizes that it's very important to stay up to date in medicine. We know medicine is ever evolving, and so staying up to date on the most recent research and evidence-based practices is important. And this study, its goal is to actually update these guidelines every 4 years or so. So since this was published in 2001, we can expect new guidelines in the next year or two. Lastly, prioritizing Rome 4 criteria, since it's been shown to increase the specificity of IBS, and then applying that multimodal team-based approach to treating IBS. And these are my references. So I know that was a lot all at once. Hopefully you guys can take this presentation and apply it moving forward. But thank you again for your time, and I'll take any questions if there are any. And I love Dr. Cannondale's comment. It's difficult to hypnotize the gut. Yeah.
Thank you, Michelle. It was great.
Thank you both for the excellent presentations.
I see you guys on the didactic if there is no other questions.